Okay, thank you very much for that introduction. I'm delighted to be speaking to you today, this morning. A scientific approach to health communications. Does it work? So that's what I'm going to be talking to you all about in the next 10 minutes. And I hope to introduce you to DMI and the work of DMI, to explain how we use scientific approaches to maximize the impact of our campaigns, and also to demonstrate and show you the evidence that this approach works. So for the past 15 years, we at DMI have been pioneering the delivery of scientifically designed behaviour change campaigns using radio, television, and mobile phones. Our vision is to cost-effectively improve the lives of millions of people, and we are driven by the opportunity to improve children's health. We currently work in sub-Saharan Africa, and we're working in 9 countries across the region. So DMI was set up to bring together the worlds of science and the worlds of media to improve health. From the world of science, we use rigorous epidemiological approaches to inform and evaluate our campaigns, plus the focus on using data and evidence to design the campaign. And from the world of media, we combine that with the storytelling techniques that will engage our audiences. Using evidence, insights, and best practice from both of these worlds, we developed a methodology that we called Saturation Plus. So Saturation Plus draws on all the many insights from media, science, and also from the advertising world. And it breaks down into 3 key components: saturation, science, and stories. So saturation, this point comes from the advertising industry. If you want to get a message across to people, if you want to really change their behaviors, then you need to repeat that message many, many times. So people are exposed to the message repeatedly and therefore can absorb the information and start to shift their own personal behaviors. From the world of science, we use scientific data to inform and design the campaign and to identify which health messages to campaign on. We use qualitative research to understand the local context and the barriers to the behaviour adoption. So here we've got a photo of some of our team in the field speaking to real people, asking them about their own experiences, understanding their local context, and also why or why not they are behaving in the way that they are, so that we can then design a campaign that directly addresses those barriers. And thirdly, we use storytelling devices and strong narratives to engage audiences with content that is relevant and recognizable to their lives. We embed key messages at the moment of emotional climax within the dramas, and we use insights from our formative research to make sure that the scripts really resonate with the audiences. We pre-test all our scripts with the audiences in order to get feedback from the audiences to understand how it's being received, whether we've maybe missed the mark or maybe some concept is not understood. And then we can adapt and iterate those scripts depending on the feedback. For example, one of our radio spots from Burkina Faso describes how a grandfather brings together all his grandchildren and asks them, what's the most dangerous animal in the whole world? And the children say, is it a lion? No. Is it a rhino? No, says grandfather. Is it an elephant? No, says grandfather, it's the mosquito. This tiny insect kills thousands of people in Burkina Faso every year. And it's for that reason that we need to sleep under insecticide-treated bed nets. And that's just one of the little stories, little vignettes that we put out on radio in Burkina Faso, in one of the countries that we're working with. So we try and use storytelling techniques, maybe storytelling techniques that come from the local context, something that's very relevant and recognizable to them. So we use a wide range of formats, depending on which channels the audience are exposed to. So on radio, we use 60-second spots. We find that these are highly cost-effective because you can produce them once and repeat it many times. We also produce interactive programs on radio that can explore concepts and themes in a bit more depth and also allow the listener to call in and ask questions and allow some interactivity. On TV, we find, given the airtime is more expensive, that 60-second spots are often the most cost-effective way of achieving behaviour change and really getting that message across many, many times. And we're increasingly working with mobile phones. When the audiences we're trying to reach have access to smartphones or maybe more basic phones, maybe feature phones, we could create some audio-visual content that could engage them and they could share, or we can distribute it in a variety of different mechanisms. I've got a couple of clips I'm just going to show.
Babu, unafanya nini babu? Bado ni mdogo sana kuelewa unachokisema.
Mkunje samaki mmoja. Mkunje. Doto, hebu mpe huyo samaki mmoja mkavu. Ajaribu kumkunja huyo sasa.
Sasa nimeelewa. Usemi wa wahenga walikuwa wakisema samaki mkunje angali mbichi.
Ndio, nasaidia akili ya mwanao kukua na kukumbuka. Lakini sasa lazima muongee na kucheza naye tangu anapozaliwa. Kusubiri hadi awe mkubwa haisaidii tena. Ukitaka mtoto wako awe na akili, njia nzuri zaidi ni kuongea, kuimba, kumfundisha na kucheza naye tangu anapozaliwa. Wazazi wenye busara wana watoto werevu wenye afya.
So that was a short film that was broadcast on television in Tanzania as part of our campaign to promote parental stimulation of young children. It's part of a wider stunting campaign, so encouraged nutritional behaviours and also parental stimulation behaviours, encouraging parents to engage with young children. I'm just going to click it forward. But so I've described to you DMI's saturation plus methodology and also talked about some of the formats that we use. But does this actually work? What evidence do we have that it works? Well, to generate to generate gold standard evidence, you need to conduct a randomized control trial. And it's very difficult to conduct randomized control trials with radio or television campaigns across wide geographic zones. However, this is exactly what we did. Burkina Faso has a very unique media landscape. So the national radio station is very unpopular, and most people listen to community radio stations that broadcast in local languages to relatively small geographies. And so this unique landscape allowed us to conduct this randomized control trial. We were able to identify 14 different geographic clusters and divide them into two arms. One was the control arm and the other was the intervention arm. And then we conducted a 3-year campaign in the intervention arm. So the campaign was working with 7 partner stations, 7 each in a different cluster. We broadcast for 35 months, every single day of the year, broadcasting 10 radio spots per day, and 2-hour interactive shows every single night of the week, so 5 nights of the week. We were broadcasting in 6 local languages. We weren't broadcasting in French, which is the lingua franca, but we were broadcasting only in local languages. And the campaign focused on encouraging parents to recognize the symptoms of malaria, diarrhea, and pneumonia. So this is Marietta. When she was 1 year old, she contracted malaria and felt very, very sick. But her parents didn't really know what the matter with her was. They thought that she'd been cursed by a bird flying over her, which is a local belief in the area that she lives. And she fell into a coma. Her parents and her father went and sought treatment from a local traditional doctor, but none of the remedies worked. and her parents were becoming very frantic as she had been in a coma for a few couple of days. But a neighbour came and spoke to the father and said, I've heard a message on the radio. I think these symptoms are the symptoms of malaria, and you need to take your daughter to a health facility to get treatment, and then she'll be cured. And that's exactly what the parents did do. And now she's still alive because of the radio campaign. And the people in her village all called her child of the radio. And so she's just one of the children, and it just gives you an example of how the radio campaign can save lives. So I described this randomized control trial. We had an intervention arm and a control arm. And at the end of the trial, we were able to compare the data for consultations in malaria in the control arm and the intervention arm. And we found that after the first year, there was a 56% increase in malaria consultations. So that's the increase in the number of parents recognizing the symptoms in their children and taking their children to see the health facility in order to get appropriate treatment. In the first year, there was a 39% increase in pneumonia consultations and a 73% increase in the number of consultations for severe diarrhea. We were encouraging parents to recognize the symptoms of severe diarrhea. So we used these findings and an epidemiological modelling tool in order to estimate how many lives were saved as a result of these shifts in behaviours. And the estimate suggested that approximately 3,000 lives were saved during this particular campaign. And so that's 3,000 lives just like Marietta. A health economist conducted some cost analysis of this campaign and discovered that it was a very highly effective campaign, a highly effective way of shifting behaviours that can save lives. And when you compare that with other maternal health interventions, it's among the most cost-effective. So to sum up, we believe that a scientific approach can be used to maximise the impact of a media campaign that is trying to change health behaviours. And we now have evidence that this approach can work, and it's a very cost-effective way of saving lives. Thank you.